Good evening, everybody. We are here at the Cambridge workshop on Scleroderma with Professor Francesco Del Galdo. And I would like to ask you a question, Professor. In the EULAR recommendation for the treatment of systemic sclerosis, it has been mentioned for the first time a vascular therapeutic continuum. Can you explain us what you think is it?
Yes. So thank you for the question. It's a concept that has been in the field for some time, but now finally we have the evidence to really spell it. Basically, the vascular disease in scleroderma is one disease, and what we have mentioned as severe renal, recurrent digital ulcers, all the way to pulmonary arterial hypertension, they are not different diseases, but they are different manifestations of the same process. And finally, the evidence from clinical trials has showed that unequivocally. So, what does it mean? It means that patients that manifest recurrent digital ulcers are patients that have a more severe vascular disease. And in fact, we know that those patients have higher risk of pulmonary arterial hypertension. Now, there are case series showing that treatment of digital ulcers with endothelin receptor antagonists and PDE5 inhibitors indeed reduces the risk of onset of pulmonary arterial hypertension. So, what have we been learning? That what we call onset of pulmonary arterial hypertension in reality is our ability to detect an increase in pressure from a biological process that's been there for years. And for the first time, we were able to say that if we are ever able to measure this increase in pressure, we shouldn't waste time in giving a single drug, but we should treat upfront with a dual treatment, PDE5 inhibitor and endothelin receptor antagonist. The corollary of this is that if patients are already treated with dual treatment for digital ulcers and they have a diagnosis of pulmonary arterial hypertension, then we should go readily to the next step, which is the second level intervention that is either Selexipag or Riociguat, with the caveat that Riociguat cannot be given with sildenafil. So it's either a switch, or in case of Selexipag, you can add on treatment. And so we are, by placing this disease in a continuum, now we are able to think of a vascular disease and a stepwise approach to this disease. We try to summarize this in a flowchart in your recommendation, and this is for rheumatologists, so we needed to be very careful of how detailed we were in spelling the ERS guidelines. But the concept we wanted to forward is, once you diagnose pulmonary arterial hypertension, your job as a rheumatologist is not done. You should then monitor these patients every 6 months, every 3 to 6 months, and make sure that they remain in low ERS risk. If not, you need to step up the approach to the second level intervention.
Thank you very much. I think it is very clear and useful for all of us.